So the results basically are going to depend on the methods, okay? And as Anup has rightly mentioned, the selection and description of the participants, technical information, what are the primary and the secondary objectives or the outcomes, and of course identifying the methods and procedures which are involved, and an appropriate description of the statistics. So I'm actually going to use this study. I had actually presented this at WIROC 2 years back, and it's coming to print, and I'm going to just sort of take you through the steps, how you can actually convert it to the point where it is published. Okay, so when you present something, it's very preliminary data, but to write it, actually, it takes a lot more effort. So for example, this was the background, it started off as a retrospective study, of spinal deformities who were treated, and some of these patients underwent a CT scan. So then I said, okay, let's just look at what the breach rates are in the CT. But then all patients don't get a CT done. It's only where you suspect that there's a breach, you'll get a CT scan done. So we looked at all the children who were under the age of 12 years, who either had kyphosis or scoliosis, okay? And we looked at their breach rates. So you can see that one is an example of a uniplanar deformity, that's kyphosis, and the other is an example of a multiplanar deformity, with scoliosis. So we had only 15 children with a mean age of 10 years. This was a non-consecutive series, as in all patients who were operated, there were around 40 patients and only 15 underwent CT scans. Again, this is mentioned very clearly. And they underwent the same technique of free and pedicle screw placement. And the outcome measures, the primary outcome measures was the assessment of the malposition on an X-ray and on a CT. And then the breaches were looked at by two observers, on an X-ray measured separately and then on a CT measured separately. Now this is the classification for how you look at breaches on a CT scan. All right, so you need to know this is important for the methods because you're going to report the results based on this. And then the malposition screws were graded. And of course, you have to look at the inter-observer, intra-observer variability based on what type of study you're looking at. And then you're looking at the sensitivity, specificity, PPV and NPV based on how you compare the X-rays and the CT. And the CT is the gold standard for assessment. On X-ray, you will underestimate. So now we come to the results. How do you kind of look at the results? So you have to provide a detailed report on the data obtained. It's obviously going to differ. It's obviously easiest to write a case report because there's just one case. You're looking at what you've done for that patient, and then you're following it up, and you're seeing what happens. So that's the simplest thing to write, probably the best way to start for someone new. A case series, again, is a consecutive series of patients treated with one procedure, and then you're sort of following up what happens to them, and you're reporting the results. A comparative study is basically where you have two groups, or three groups maybe, and you're actually comparing what's happened to these patients, okay? Of course, if it's retrospective, that means the patients are recruited after the study has started, and prospective, if actually you're recruiting after from day one. The study is either retrospective or prospective based on that. Now the measurements should be prospective, always presented metric values, and you have to provide absolute numbers. So you can't just say 50%, you have to say 20 of the 40. So what is the denominator, what is the numerator, you need to mention that very clearly. And try to present your data clearly and in a logical fashion. Statistical results, very important. You have to provide the means. So the descriptive statistics, the mean, the standard deviation, always provide the range, medians and IQRs. Okay, so this is the descriptive statistics, what we call. You have to quantify the findings, present them with appropriate indicators. Always you present with confidence intervals, etc. So the p-value and the confidence intervals is something that is a different talk. It's on statistics. So for example, in this study, there were 154 pedicle screws which were analyzed. There were 65 in the uniplanar group, 89 in the multiplanar group. You can see here that 23 malposition screws, that's 14.9%, which were identified on the plain radiographs. And 43, that is 27.9 on the CT. So that means 1 in 4 screws was actually malpositioned if you looked at the CT. Of these, there were 17 grade 1 breaches and 10% of grade 2 breaches and 6% of grade 3 breaches. The grade 3 breaches are the significant ones actually. Now in that, when you look at it, you basically, so you looked at the whole series to start with, and then you kind of compare the two groups. So when you looked at the uniplanar group, there were 31 out of 89, which was in the multiplanar, and only 12 out of 65 in the uniplanar. So what does this show? That you're going to have a higher rate of breach in a multiplanar deformity. In a scoliosis, you're more likely to have a breach. And then of course you looked at all these values like sensitivity, specificity, etc. Now the follow-up. Now this series did not require a follow-up. Why? Because we're just looking at the breach rates, which you're seeing on the CT scan. But if you're looking at outcomes of arthroplasty, then you have to have at least 2-year follow-up, okay? And most of the journals will give their criteria. Most of the good journals require a minimum follow-up of 2 years, not average follow-up of 2 years, okay? And if the follow-up is shorter, then you have to provide scientific evidence to say that why I don't require more follow-up. You have to mention patients who are lost to follow-up. So it's impossible that you have 50 patients and you have 50 patients at the end. Usually you will have some patients who are lost to follow-up. You have to very clearly mention that in your results. Now the tables and the figures. So basically you got to check that all your numbers match out, in your text and in your figures. You have to see that everything, there's no discrepancy. And you do not repeat the data which is in the tables again in the manuscript. There's no point in just kind of repeating yourself. So for example, these are some of the tables, which are just giving all the information so you don't have to repeat in the text, okay? This is the comparison of the two groups, okay? This is the details of the malpositions, okay, on CT X-rays. And this is the analysis. This is actually the most important table where you are looking at the analysis and comparison. Now the discussion has to be succinct, okay? What does your study show? Is your hypothesis affirmed or refuted? And the importance of the article with regard to the relevant literature. And how do your results fit in? So for example, this is a summary of all the literature on malposition pedicle screws summarized in a table. You don't have to write everything again then. So the discussion, you have to analyze the data. You have to discuss the strengths and the limitations. And will your results change the clinical practice? So basically you can miss a malposition screw on an X-ray, all right? And you don't have to repeat stuff. The conclusions have to be, linked to the goals of the study, and you should have no unqualified statements. And you distinguish between clinical and statistical significance. Avoid making statements on economic benefits unless you've done an analysis. The conclusion, so in this case, was that there was a discrepancy between the identification of pedicle screw breach on X-rays versus CT, and the ability to detect a breach on plain radiographs is lesser in multiplanar deformities. This is what we proved from this study. References should be always in the order of appearance. This is the Vancouver style. Only relevant references. Avoid citing unpublished material. Check the primary sources. Don't just copy from the other paper, that this is the reference, so I'm going to put it in. And don't use secondary sources or cross-references. Do not use inaccurate data, numbers, results, or follow-up. Do not underreport your complications. Do not hide conflicts of interest if you have with any companies, etc. Do not copy any text verbatim from any other paper. All these things will get you sort of into trouble with the journal, and you can get blacklisted, and you might have to retract a paper later. Research ethics. Basically, it's about scientific credibility. You may want a paper, that's fine. It's about your reputation, and it's about benefiting others if the reports, are genuinely done. All right? Thank you very much.